Dr. Bhatti is joining in a moment.
सर आप ज्वाइन कीजिए सर. सर नमस्कार.
Good evening.
Good evening to everyone. Good evening. Good evening, Dr. Sushil. Good evening, Dr. Shankar.
Good evening, sir. Dr. Sushil, Dr. Anil Jain is one of the pioneers of all the text and books on tuberculosis, and I have known him since my junior resident days when he was a young man, and now I am an old man, so certainly he is older than me.
But there is no signs of age in Dr. Jain.
No, it's good. You know, it's good that we keep on stimulating and pumping every one of each one of us. You know, this is something called mutual admiration society.
I think age is just a number. And, it's all in the mind whether we are aging or not. Yeah, physically.
I hope so.
Some things, but then of course it's just a number.
Dr. Jain has to do a lot of revisions of Turek now. You know?
No, this revision is coming this month.
This month coming, so.
Yeah, 8th edition is coming this month.
Hello, very good, sir.
It is already in press.
Yeah, very good.
So what is new?
सर आप मेरे को पूछ रहे हैं?
दोनों को पूछना है, सुधीर को भी और आपको भी.
बस कुछ नहीं चल रहा है सर.
TV is very old, but still it is new today. You know.
Every day.
Every day it is new.
So that is why, you know, when this British JBJ's title was to be given.
Yeah.
So I thought this is the best title, fresh look at the new old disease.
Yeah. TB is always challenging and always new and always difficult to diagnose sometimes.
A day will come when we'll have to develop some new culture media to, you know, grow these, you know, organism. Very, very difficult task we are facing.
And now they have to work on some new drugs also.
Yeah.
Yes.
Unless a new group of drug comes, because, you know, we are just revolved around old drugs for last 30-40 years, and now the drug resistance rate is alarming.
No, I have now 3 or 4 patients on this new drug, bedaquiline.
Yeah.
And that has to be got from the government's centers. But at least one good thing is that after this TB notifiable disease, at least some improvement in record keeping and all that is being happening.
That's right. Yeah, no doubt.
Okay.
No doubt. Yeah. Chances, even the defaulters are less.
So shall we test the slide sharing once before we start?
I think so.
Yeah, Professor Jain can do a slide sharing.
Yeah.
Okay, I'll just share my slides.
Dr. Bhatti is there. Good afternoon, Doctor. Good evening, Dr. Bhatti. We have not met formally, but I can see you now. So welcome and to this Capio session. And I understand you are a very experienced neurosurgeon in Apollo. And we hope to meet you soon. Dr. Srivastav and Dr. Professor Anil Jain are there. And whenever you say, we will be ready to go. 2 minutes to go, I think. on my watch.
I think I need a bit of advice because probably some change in the Zoom, because I'm sharing the slide. I have already opened my slide.
Yeah. So then you have to click on the slide share,
Oh, yes, I'm clicking the slides here.
and then you have to use alternate tab to reach to that.
Files.
So
Okay. So these are the files. No, basics. It's not opening the this desktop.
Dr. Sushil Jain has been, Dr. Shrija, he has been given option of being co-host. Then
yeah,
only, na?
be the co-host.
Okay.
Microsoft PowerPoint, open system.
Sir, have you minimized your presentation?
Should I minimize it?
Minimize
you
it,
minimize
and
it.
at the bottom you open it and then share it.
Yeah, Zoom would like to record this computer screen.
Okay.
Okay. Make it okay.
It's open system preferences and deny.
ओपन सिस्टम प्रेफरेंस को छोड़ दो सर, डिनाई कर दो, देखो क्या होता है.
मैंने तो
नहीं, मैं
open
then
वाला
it
कर
won't
दिया.
be allowed.
नो. ओके, ओपन सिस्टम प्रेफरेंसेस.
वो कर दिया, लेकिन
हाँ.
Okay, let me see.
Jitendra, Jain sir, you can also mail the slides to me if there is an issue.
I don't know whether it will come because it should be
heavy file ना.
Okay.
So आप सर share screen करो, फिर उसमें
should I minimize this presentation or should I remain
No,
on
no.
this?
आप open करो presentation first.
कर दिया, open किया.
उसको फिर छोटा कर दो.
Minimize.
हाँ.
Okay.
Minimize ना करके छोटा कर दो, फिर then you go to share screen.
अच्छा, छोटा कर दिया.
उसमें then you click on your presentation.
I don't know whether what is this happening. I'll enter again actually. Okay, this is what now I do the screen share. And what is getting is Microsoft unknown and desktop one.
तो डेस्कटॉप 1 में जहां आपका प्रेजेंटेशन है,
should I do open system preferences?
No, not
allow Zoom to share your screen.
Yeah, allowed to share your screen. Yes.
And इसमें there is cancel and open screen system preferences.
Open system preferences.
Open system preferences that I have done.
Now, in that you must be having some video or screen sharing.
No, there is the screen share is there.
Yeah, so you have to allow that screen share.
Okay, share. Open system preferences, and then that's it. Shall I call my son to do it?
Meanwhile, Dr. You would like to take your screen?
Yeah.
Screen share नहीं हो रहा है. Filter. Okay, now this is.
Now it's working.
What has come? Connecting to audio.
So your screen was visible in between.
My presentation was the.
No, the the browser was visible. The one showing
मैं इसको कर दूं.
the attendee screen.
ये screen share कर दो. You know, I could not get the better person than him. He is a professor at CMU Pittsburgh in computer science.
Chalo, very good, sir. Yes.
That's the best possible help you can have.
Yeah.
Now, phone bachi.
Open systems. कौन सा पासवर्ड?
पानी आने दो.
Until it is quick. Yeah.
To open
It,
the Zoom will close down and it will reopen.
okay. हाँ करो करो. Yeah.
Dr. Jain, could you share the screen?
I think he's disappeared from the screen.
He has logged out and he'll have to log in again.
Yeah, probably. But I can't see Dr. Aditya Singh Bhatti also. Is there?
He's there. He's there.
Yeah, he is there.
Oh,
Audible, sir. Hello.
yeah, you are. Yeah.
Yeah, he's entered again. Yeah.
So sorry.
Okay.
Working now.
Okay, good. I think let it be like that because his speech is first, and if Dr. Sushil Jain is okay, then we can start.
Sir, please, sir.
Okay. Good evening, everyone. Welcome to this special webinar between the GAPIO, which is the Global Association of Physicians of Indian Origin, This is something which I was exposed to in a couple of months ago, and this, as I find mails from them, is a fantastic organization all over the world of Indian physicians who are actively participating with each other. And the Association of Spine Surgeons of India, actually, Dr. Chabra, our ex-president, introduced this cooperation between GAPIO and ASSI, and I am Dr. Shankar Acharya. I am the president of ASSI at the moment. And I welcome you all to this evening, August evening, for this special session on tuberculosis of spine. And we have two great speakers who are personal gurus for me, Dr. Anil Jain, who I have known since my student days, and Professor S.K. Srivastav, who I've known from when I started practice almost 30 years ago. I will leave the introduction to Dr. Bhatti, who is a consultant neurosurgeon and in Apollo Indraprastha Hospital. And my job is to introduce him as well. And welcome Dr. Aditya Singh Bhatti to this special session. He's a consultant neurosurgeon and spine surgeon at Indraprastha Apollo Hospital. And he has vast experience in managing brain as well as spine disorders. His main areas of interest are minimal invasive brain surgeries and spine surgeries. And he's published a lot of international and national papers, and he actively participates in all meetings and international sessions. Welcome you, sir.
Thank you.
I request you to take over and introduce our two special guests, Professor Anil Jain and Professor S.K. Srivastav.
Thank you. Thank you so much, sir. Good evening, everyone. A little hassle was there, but let's begin. I would welcome everyone. Since everyone is here, let's get started. And we'll be talking about the managing COX spine, its importance and its consensus and controversies in the treatment of spinal tuberculosis. So why it is important? We have been managing COX spine for a while, either medically or medically and surgically. So spinal tuberculosis continues to be a cause of disability and poor patient satisfaction due to delayed diagnosis and inappropriate management. And more importantly, with emergence of drug resistance, management becomes much more challenging. And currently, because of the lack of consensus and difference, and more importantly, difference in expert opinion in management. So we have to listen to the experts to how to go about it. More importantly, there are the consensus whether to be, when and at what time the ATT has to be started, for how much time it has to be started, and more importantly, when surgical intervention has to be started. So these are the things. Let's listen to our experts. First speaker is our Dr. Anil Jain. He's a professor, head of department orthopedics and dean of UCMS, and he has been awarded with numerous fellowships, including FAMS and FRCS, and he has published more than 143 articles in peer-reviewed journals. He has unique distinction in publishing highest number of articles on TB spine in the world, and he's editor-in-chief of Annals of National Academy of Medical Sciences. So he had delivered more than 500 lectures in various PG courses. Sir, can you please, it's over to you, sir. Dr. Jain.
Thanks, Dr. Bhatti. Thanks, Dr. Shankar, for a generous introduction. And thanks, Global Association of Physicians of Indian origin and ASSI. Well, I think while framing these index TB guidelines, we framed about 200 questions, and we tried to generate evidence-based answer to those 200 questions. Then probably all those question answer have been compiled in the form of this monogram. And then we realized that what are the areas where consensus has been achieved and where there are continued controversy, where we all have to work for some more time to answer those controversies. So the mandate of today's talk is medical management and when to stop ATT in spinal tuberculosis. Well, we know it is extrapulmonary, and as extrapulmonary, it is paucibacillary, and hence there is a lower bacteriological diagnosis. For tuberculosis spine, the important basic issues are that here diagnosis is delayed, evaluation on treatment is difficult, uncertain. We do not know that we have treated enough so that we can stop treatment, because we rely on indirect evaluation. And as a result, more controversies, more opinions, more school of thoughts, and confused average practitioner. Diagnosis of spinal TB by suspecting a case and ascertaining the diagnosis by imaging or microbiological, molecular, and histological diagnosis. But the bottom line is that diagnosis must be ascertained in all cases. If a case presents on MRI as a consecutive vertebral body involvement, intact preserved disc spaces, prevertebral soft tissue collection, which is low signal in T1 and bright in T2, septate paravertebral abscesses, epidural involvement, you could see this epidural involvement, and vertebral intraosseous abscess, then more or less we are sure that we are treating a case of tuberculosis spine, and that is what is generally possible in about 90% instances. In remaining instances, if there are heterogeneous vertebral body involvement with heterogeneous signals in different vertebral body, then we must take biopsy. Ideally, you may take biopsy in all cases, but in these patient cases, it is a must, and we must take biopsy because there is no place for a treatment of TB as TB spine without establishing a diagnosis. Now, these are the laboratory methods. Culture, organism demonstration, which is gold standard, reliability 30 to 50%, molecular methods. We have generated evidence in last 5 years after the index TB guidelines in almost 90%, AFB smear 10 to 30%, histological diagnosis 60 to 90%. So you could see that none of the laboratory methods are 100% able to ascertain the diagnosis. And that is why we believe that tissue must be submitted for all simultaneously to ascertain diagnosis in 100% instances, as we have published recently data in Indian Journal of Orthopedics last year, and another study we are going to publish this year, which says that if all the tissue is submitted to all, then more or less in 100% instances, we are able to ascertain the diagnosis. So while treating a case, we must do an HIV testing, X-ray chest. But what I want to emphasize that X-ray of the spine or part, although it has a limited role in early stage for diagnosis, but it is useful to evaluate treatment response in immediate post-treatment period. And hence X-ray, baseline X-ray of the spine must be available with the clinicians. Now, once diagnosis is ascertained, mainstay of treatment is continuous, uninterrupted multi-drug ATT. As in contrast to multibacillary pulmonary disease, it is an paucibacillary disease. Bacteria are slow growing, fastidious. Most antibiotics does not act on mycobacterium. They have a lipid cell wall, that is why poor penetration of antibiotics, and macrophages engulf mycobacterium. Hence, generally, even most the ATT does not enter in macrophages except pyrazinamide. So multi-drug chemotherapy becomes essential because there are 4 types of mycobacterium in a lesion. Some are extracellular, rapidly dividing, acted upon by INH, streptomycin, and ethambutol. Extracellular, slowly, intermittently dividing, acted by rifampicin. And intracellular, intermittently dividing, acted upon by the pyrazinamide. Dormant bacilli, there would be some dormant bacilli where no drugs act, and these bacilli, they remain dormant for years in the different tissues in the body, which are the most common causes of relapse if the disease gets reactivated later in life when immunity goes down. Now, the next issues besides the multi-drug therapy is, should we give every day or should we give alternate day? Now, alternate day intermittent regimen came, which was scientific, based on lag effect of the bacteria, that when a bacteria is exposed to a drug, then undergoes suppression, and it remains suppression for 24 to 48 hours, even if the drug is withdrawn. So this was intended to improve compliance, and so that we can give a supervised ATT, and 3 times per week were recommended. But then it continued for 10-15 years, and later on it was realized that if one dose is missed, then the consequences were very serious, risk of emergence of drug resistance, and hence there is a policy decision that no more intermittent, it's all daily doses regimen. Now, then question comes, what is the duration of ATT? Pulmonary TB, 6 to 9 months. So the argument is that when it works for pulmonary, then why not for bone? Bone is, bacterial load is less, it's being paucibacillary. And that is why world over opinion is divided between 6 months, 9 months, and 12 months. While framing the guidelines, we did a brief review of literature on this subject, and we found that there is uncertainty about optimum duration of treatment for TB of bones and joints. And because there is a lack of consensus about what constitutes healed status in the literature. So what is in and what is out? Drug combination settled 4 drugs to begin with, and then continued with 3 drugs, daily or intermittent, daily doses, and duration of ATT, healed status. I think that till the healed status is achieved. So the question when to stop will go on case to case basis. There are a strong proponent of 9 months, and I'm aware few good articles being published, prospective studies published in last 5 to 10 years. But I believe that if you are treating with a culture sensitive report, then probably a shorter duration can work. But if you are treating on clinical imaging basis, then ensure that lesion has achieved healed status. Now, similarly, for children, I think we have to be very sure about the doses being given for the children, and we must ensure that correct doses are prescribed for the children, and that is why it is recommended. Take weight on every visit and modify the doses as per the weight gain of the child. Now, when you have started treatment, you need to monitor the patient on initiation of treatment. Well, clinically, by well-being, hematologically, ESR starts declining. X-rays, as I said, X-rays earliest to show improvement in the form of remineralization and sharpening of disc margins, which earliest may be appreciated at 2 months. No investigation, no MRI can be useful at 2 to 3 months time. It is only plain X-rays which is useful, and that is only possible if we have a pre-ATT X-rays in our record so that we can compare. MRI not useful in first few months. Now, why we want to monitor it? Because we are concerned about eliciting, knowing that whether there is a good response to the treatment or there is a failure of response to treatment. So the question comes, when to stop ATT? See, why it is simple for pulmonary TB? Because sputum conversion followed by 4 to 6 months ATT, and hence 6 or 9 months regimen are fine. While for osteoarticular tuberculosis, being a paucibacillary, our bacterial diagnosis is low, and we cannot have repeatedly tissue as one can get in sputum, that we cannot ascertain that bacterial sterility of the lesion has been achieved and can be ascertained, and hence optimum duration of ATT remains an unresolved issue, and we rely on indirect evidence, whether it is X-ray or whether it is MRI, whether it is PET scan or anything else. Till 2018, whatever world literature was there, they followed pulmonary regimen, and we in orthopedics or spine lesions, we wrote healed status. That is duration of ATT as by pulmonary TB with no relapse for 2 years. That defines the healed status, and that is what was being taken in almost all articles. And here lies the importance of follow-up being reported by various studies. If some study says 1 year follow-up after stopping ATT, then that may not be good enough to say whether healed status is achieved or not. And all these patients, lesions were evaluated by X-rays, hematologically, and by clinical response. And this is what I meant, that if this pre-ATT X-rays, one could see demineralization and increased prevertebral space, which on treatment, this soft tissue shadow will regress and bone become mineralized, borders become sharper. And at the end, 70%, at the end of treatment, 70% will achieve bony fusion, osseous healing, while remaining 30% would have a fibro-osseous healing. So it is possible by X-rays, we can say that it is improving. And at the time that what is the final picture? But the limitation is that healed lesion to stop ATT. What is the point when ATT can be stopped? Cannot be ascertained by plain X-rays, because X-rays lag behind than the clinical picture. And I'll give you this example. 18 months ATT given to this patient, and you could see this. These are denser vertebral body and border getting sharper. When MRI was done, it was still active, and you could see there was a collection in the sauce. And when aspiration was done, it is a thick pus of an active disease. Had it been a just watery collection of a sterile collection, then it should have been watery, which is generally in this case it is not there. So it suggests the disease is active. So we took contrast MRI in assessing response treatment as a criteria of healing on MRI, and that includes complete resolution of pre and paravertebral collections or abscesses, resolution of marrow edema of the vertebral body and bone, and fatty replacement or calcification of marrow edema as suggested by ISO intense T1 and T2 weighted images in contrast enhanced MRI. So these are the criteria to say label as a healing. And you could see here, this is an active disease, prevertebral collection and intraspinal collection, and this is completely resolved. Bone has undergone, there is no edema of the bone. You could see this abscess has completely vanished here. So this is an MRI findings of a healed lesion. So what is the endpoint of treatment? To define an endpoint of treatment, we took a study where at 8 months, 12 months, and 18 months contrast MRI were done. And what we found at 8 months, 30.5.2% showed healed vertebral lesion, 12 months 60%, 18 months 90%, in spite of clinical and hematological improvement. So we concluded it is unscientific to stop ATT by fixed time frames. Lesion must be evaluated clinically, hematologically, radiologically, and contrast MRI to document healing of vertebral lesion. Now, since the limitation of MRI-based healed status was that contrast enhancements may continue for many months despite healed lesion. And this is what has been reported in many other studies for pyogenic diseases as well, that enhancement may continue for longer time. And you could see this example here, this enhancement, the lesion, whether this enhancement is because of active disease or because of continued inflammation of healing. So while this could be evaluated by PET scan. So we took another study where introduced PET in all those cases, because PET has proven ability to discern metabolic activity. So we have taken the similar cases where diagnosis was ascertained and then the patients were evaluated. We had a better diagnosis in these series, but the conclusion were the same. Out of 37 consecutive cases which were histologically diagnosed, the PET shows healed lesion in 28 of 28, while MRI showed at that point of time only 52% instances. So it means PET is better to ascertain healed status or healed lesion. However, duration was again the same. So we again concluded treat till healed status demonstrated. And one could see here, this is an active disease. This is 9 months, and you could see fatty replacement of the body has taken place in T1 weighted. There is no abscess, and PET shows no activity. And at 9 months, at 10 months, this ATT was stopped. This status achieved at 18 months, and you could see negative PET, no activity in the PET. So that is how these are the two cases of this study. Now I'll give you one example which will put things a little better. This is an L1 disease where on MRI, all classical findings which I described, 7 findings were there. So CT guided biopsy was done, and CT guided biopsy, we ascertained diagnosis by gene experts, molecular, AFB, and it was sensitive, arsen and isoniazid sensitive. So ATT was given, and at 15 months, one could see here, this lesion shows this X-ray. This is little better. But then when we looked at MRI, one could see intraosseous shadows, intraosseous lesions, which on, you could see this is the intraosseous lesions, and which on enhancement, contrast enhancement was enhancing. So these were labeled as enhancing intraosseous abscesses. And when aspiration was done again, and then again on histology, it shows active granulomatous disease. Although at this stage, molecular methods are of no use because genomes may be positive even in a healed lesion. So we relied on histology. So we give ATT for another 4 months, and then this patient achieved the healed status. So to conclude, ATT, 4 drugs for 2 months, 3 drugs for 10 months, daily doses, close monitoring for neural and progression, and then some patient who requires surgical intervention, we need to operate. Total duration 12 months, extendable to 18 months on case-to-case basis. These patients need to be follow-up, repeat X-rays of spine every 3 months on ATT, repeat MRI scan at 12 or 18 months follow-up, but certainly not in the first 6 months. Follow-up, once we have stopped ATT, follow-up after the end of treatment, every 6 months for at least 2 years for any new symptom, for any recrudescence. Now, the new things which have come in chemotherapy is a failure of drug treatment in TB spine. And I think that is a real worry at the moment to all persons who are treating TB spine. You could see a lesion at the start of ATT, and at 9 months, one more body has been added, and almost the similar lesion. So what the clinician's concern is my diagnosis right? Am I dealing with TB or any other granulomatous disease? And if my diagnosis is right, is it paradoxical reaction, which is benign thing, or a drug resistance? Paradoxical reaction, classically described as clinical deterioration of lesion or development of new lesion in immediate post-treatment period in patients who had initially improved on ATT for few months. It occurs in early phase of treatment during the first 3 months. While drug resistance, there is no improvement from the beginning, and lesion continue to deteriorate immediately, even after starting of ATT. There is no improvement until an effective second line ATT started after making a diagnosis. Now, this incidence is a many years old from the sites. 2.3% MDR TB cases among the new cases, 17.2% amongst the previously treated cases. So you can see how alarming this problem is. This is classically defined as a primary resistance when no ATT is taken and infection is from acquired resistant organism. We were not getting this primary resistance about 5 years or 10 years ago, but now we are getting a lot of primary resistance, which are at first instance are getting a primary resistance. While acquired resistance are those which develops during the course of treatment as a result of non-adherence of recommended regimen or a faulty prescriptions. These are definitions based on the sensitivity, whether it is monoresistance to any single drug among the first line drugs, or a polyresistance 2 or more first line drugs, or MDR when resistance to rifampicin and INH, and XDR where resistance to rifampicin, INH, fluoroquinolone, and one injectable other than streptomycin. It's a bad picture. No part of the world is without a report of a resistance case. We can find cases in almost all countries. And this is the 2006 global distribution of MDR TB cases among new. Even the XTR cases have been reported in almost many parts of the world. And one could see the number are mounting. And the implication is that as a result of this, deaths are mounting. Because the implication is 5-year survival rate for a person with MDR TB is 50%. It is the same as for the person with TB in 1904 in the pre-ATT era. So you can see how alarming this problem is. How to suspect? If at 4 to 5 months of treatment, patient doesn't show a clinical improvement or shows a radiological deterioration, deformity, spinal deformity is deteriorating, or a new lesion has appeared, or a new cold abscess has appeared, or ulcer sinus failed to heal, or wound undergo dehiscence in a post-operative case, then these are the patients where our radar for presumptive drug resistance should be high. In such cases, we must have a detailed drugogram, what drugs patient have taken, in what doses, what duration, and what was the regularity of treatment, and list a drug which has not been taken, because that is the drug which is going to be most useful. We must obtain tissue by any method, whether by percutaneous method or debridement of the lesion. In fact, the advantage of early debridement is that it reduces the bacterial load as well. Send the tissue for histology, smear, culture, genotypic analysis, gene expert, line probe assay to the 2 national accredited laboratory. And we need to, and when the reports come, and if there is a discrepancy in the reports of 2 laboratories, then treat the worst case scenario. So the advantage with gene expert and LPA is that we can get the information about rifampicin resistance and INH within 2 days. Culture reports would take some time. And if the culture report has come and demonstrated bacteriological drug resistance, then we need to modify drug regimen. The principle of chemotherapy, these are more toxic drugs. These are less potent drugs. They are used in higher number. And the principle is that we need to use a drug which has not been used. Never add one drug to failing regimen. I think I would like to stress here, because I see almost 2 prescriptions every day where after 2 weeks levoflox is being added, or from the beginning levoflox is being added. Please, this should not be done, because levoflox is drug which is a very important drug for the second line drug management. And that is why there is no advantage of adding one single drug to failing regimen, and rather we must ascertain prove the drug resistance by taking the tissue to molecular and culture. Many drugs are to be given, at least 4 new drugs should be added. No single dose, they all should be given in single dose, no divided doses, no intermittent therapy. Best drug combination should be used at first instance from the culture report. No drug should be kept as a reserve. It should be ensured that patient has taken the drugs, and surgical treatment may be an adjunct to the treatment, because maybe debridement reduces the disease load. But most important is that patient must be counseled not to stop treatment even if discomfort present, because patient must know that this is the last chance of him getting any improvement. Otherwise, the future is black. And these are the various combinations which I'm just not going to discuss. And I would suggest that in such cases, these are the WHO recommended regimen from the various combination, sensitivity not available, and you suspect drug resistance to rifampicin and INH, to all other essential drugs. So these are the various combinations, short and long, being prescribed. And I would always advise that we must use someone who is well versed in treating drug resistance cases, maybe a pulmonologist. I'll just give you, this is my last few slides. I'll just give you one example that how we have evolved in management of drug resistance cases. This girl reported to me in 2014 with backache, fever with constitutional symptom at some hospital, diagnosed TB spine in 2009. And she was carrying an X-rays. On this X-rays, classical radiological picture, 18 months ATT when stopped, good radiological signs of healing were there. So this so far is absolutely correct. Now patient becomes symptomatic again on 14 months follow-up. And that is what I say. Why do I say that you must follow the patient for minimum 2 years after stoppage of ATD? And you could see 14 months follow-up, patient was again symptomatic. MRI, by this time MRI was available, and patient has preserved this MRI, and one could see the old lesion completely healed, while the new lesion has come in L3. So again, at that time, category 2 was prescribed. So 18 months ATT was taken. And by the time September 2013, ATT was stopped. Now patient still was symptomatic, and sauce sepsis has started appearing in iliac fossa. So somebody drained a sauce sepsis also. Pus was demonstrated, and again 4 drug was started. Now by that time, drug resistance was in discussion in among the medical fraternity and among the various conferences. So the treating person has added cycloserine and moxifloxacin. Well, I think there was no logic starting just adding 2 drugs without ascertaining drug resistance, without making. But then this was the current state of knowledge at that point of time. So, and few months down the line, 6 months, MRI was performed, which shows that probably all abscesses have vanished, but this is the lesion which was still there. So he stopped all drug. Had he continued all drug, probably the patient would have been better. But then he stopped everything, and again rifampicin INH continued. And few months down the line, patient came to me at this stage. Patient reported to us at this stage. We did CT guided biopsy from this lesion, and again AFP smear was negative because there was only few drop of pus we could aspirate. So this was not sufficient material. But then there was no growth from that material on the culture, but biopsy was suggestive of a granulomatous disease with a classical tubercular granuloma. So we ascertained the diagnosis of tuberculosis, and this was, we did not stop there, and this was the lesion in January 2015, and we went in anterior debridement of the lesion through the retroperitoneal approach, and a thick clump of mass of about 4 centimeter by 4 centimeter was found in this lesion and in this sauce, and which was on culture resistance to rifampicin and INH. And when the standard second line treatment was given, patient achieved the healed status. So the message is that whenever a presumptive TB case comes, we need to investigate, ascertain the diagnosis, treat till healed status is achieved. Once healed status is achieved, follow till 2 years so that we can early relapse can be found out. If some of them do not follow this course, have a paradoxical reaction or a presumptive suspected drug resistance, then we need to investigate for drug resistance. If we are able to demonstrate resistance, then we treat it as a confirmed drug resistance. Otherwise, we treat it as a clinical drug resistance, which is now accepted by WHO as well. And these patients are treated on a MDR protocol. And this is what till 2020 in this journal Bone Joint Surgery American. So friends, thank you very much indeed for patient hearing. And I'll be too happy to answer any question.
Thank you so much, sir, for delivering such a scientific and informative talk, well demonstrated with clinical cases. I would like to thank regarding that book you published. That will be a great help for everyone. Now, our next speaker would be Dr. S.K. Srivastav. He'll be talking about surgical management in spinal tuberculosis, when, where, and how. Dr. Srivastav is presently working as a professor orthopedics at Somaiya Medical College and Research Institute, Mumbai. He is a retired professor and head of orthopedics department at Sage GS Medical College and Hospital, Mumbai. He has done his spine fellowship from Germany and UK, and he's immediate past president in Bombay Spine Society. And he has been a faculty in different national and international conferences and published more than 75 scientific papers in different international and national journals. So over to you, sir. Dr. Srivastav, sir.
Thank you very much. I will share my screen.
While Dr. Srivastav shares his screen, please type your questions in the chat box.
You are able to see my slide, please?
Yes.
Yeah. So good evening, friends. I thank APO and ASSI for providing this opportunity to me to discuss this very important topic, that is the surgical management in spinal tuberculosis. Now, we find such cases, in our part of the world, and most of the Asian countries, they have this issue. And when you find these cases, you are really in difficult situation how to manage these cases. Professor Jain has nicely described all the problems while continuing the medical treatment, and sometimes patient lands up with the such situation, and then you think what is to be done in such situation, what is to be done, where it is to be done, and how it is to be done. Now, we all know that tuberculosis is a medical disease. Usually, spinal tuberculosis heals with effective anti-tubercular medications. Surgical intervention is required to treat its sequelae. So, if the patient has neurological deficit because of the neural compression, or there is an instability because of the destruction of stabilizing ligaments, bones, and joints, or if there is an unacceptable deformity where there is a possibility of late onset deficit, in such situation, you try to intervene surgically. The aim of surgery in cases of neurological deficit where there is a neural compression is to do the adequate decompression. If there is a significant column destruction, you wish to have a very sound reconstruction, which is extremely essential. If there is a instability or impending instability, stable fixation and fusion is mandatory. In cases of deformity, you wish to correct the deformity and achieve a very nice biomechanical aligned column. Now, the judicious planning and meticulous surgical execution fulfills the aim of surgery. Now, what are the indications for surgery? Usually, you have put the patient on AKT, patient was improving, but now there is a neurological deterioration. In such situation, you try to analyze your case, and you find if there is a significant compression and patient has started deteriorating in spite of taking adequate AKT according to the weight and all those medical criteria, then you then like to intervene surgically and you wish to decompress, like in this case. Now, if there is a dense neurological deficit to start with, the patient has come to you with dense neurological deficit with bladder wall involvement, and such is the circumferential cord compression. In such situation, you don't wait and you have to do the early decompression. The another scenario where there is a significant instability, like in such case, there is a gross destruction at the craniovertebral junction. The bony element are significantly destroyed, and if you wait, there will be significant kyphotic deformity, and which will be very difficult to manage. So in such situation, you have to intervene early and try to align the column and try to fuse and fix this area as early as possible so that patient improves significantly during the course of treatment. If there is a significant destruction of the column with increasing deformity, now in this case, this is lumbar spine. If you see here, there is a significant destruction. Kyphosis has already appeared. And if we don't intervene at this stage, there will be severe lumbar kyphosis, and there will be later on problem of improvement whenever you try to intervene surgically. So in such situation, in lumbar spine, try to intervene in such situation early so that you are able to salvage the segment also. Now in this case, if you see, even in the diseased vertebra, we have put a small pedicular screw and we have tried to salvage the motion segment. So only this segment has been stabilized and one has gone anteriorly and tried to reconstruct the column by the good bony strut. And so that you intervene early and try to align the column nicely, because you don't want that further in future there will be problem. In junctional area, the tuberculosis behave very differently, because if you have a stable dorsal spine and then you have a cervical spine, at CD junction, if you have significant destruction, then it will deteriorate rapidly. Now, in this case, if you see the T1 is missing and there is a collapse of the column. And such situation, again, you have to intervene early and you have to stabilize the column and you have to support the column in such a way that it heals with medical treatment as well as your surgical intervention. Pediatric spine, it behaves differently. There are positive risk factors which has been very nicely described by Professor Rajsekara. Radiological spine at risk signs are well described. If you find any of these things, you have to be cautious and you might have to intervene early. If you find the separation of facet joint, posterior retropulsion, lateral translation, and toppling sign. The risk factor for collapse in pediatric age group, if the age at which the patient is presenting is less than 7 years of the age at the time of disease, there is a DL junction involvement, there is a loss of more than 2 vertebral bodies, and one of these radiological signs of spine and wrist signs are there, which is progressive. In such situation, you have to treat it definitely differently. The TV spine in pediatric age group is different. Why it is different? Because of the differential growth, there may be rapid progression of the deformity. Because the quality of the column is different. The bone are cartilaginous. There is a poor bone stock. And when it comes to reconstruction, the selection of implant in pediatric age group is really a challenging task. You have to use a miniature version of the implant, which should be able to sustain the column. Now, this girl, she had come to us, a 5 years old girl. She was paraplegic almost for 1 year. You can see the amount of destruction. You can see in the CT, almost these many bodies were missing. And she was paraplegic with bladder involvement. And we tried to correct it. We tried to decompress and reconstruct it. So here, what we have used a pediatric rod where it has been shaped as a U. Lower construct is the pedicular screw and the upper construct is the sublaminar wire, and it has been used as a hard seal rectangle. And in this case, the second stage, we went anteriorly, we debrided, and we have put fibula here, as you can see. And this child started walking again. It is still going on. Now, success of surgical strategy totally depends upon the adherence to the principle of surgery. The critical preoperative evaluation and execution of the plan is extremely important. Now, what are these strategies? Okay. Patient with proven tubercular spondylolisthesis, you put the patient on AKT, you continue, you watch. It has been very nicely described, Professor Jain, that you have to follow these patients. They should not disappear. Otherwise, they again come with the problem and then you are in soup. So always try to follow these cases where you have put the patient on AKT and you are just observing how the column is improving. There are situations where a patient is having spondylolisthesis, but there is no neurological deficit, but still there are few conditions in which you have to intervene early. Some of these I have already narrated. I'm going to show more examples. And there are situations when there is a spondylolisthesis with neurological deficit, which maybe along with kyphosis or without kyphosis, and then you will start deciding what surgery I have to do, what approach you have to choose, and what are the situations where one has to go anterior. So these things keep on going in your mind. Now this patient, you can see there is a significant destruction anteriorly, but still patient doesn't have a neurological deficit, but more than 2 bodies are involved. And actually, this is an unstable situation, and in such situation, one has to intervene surgically. Lower dorsal and upper dorsal area, you can see there is a translation, and this is the unstable situation, and we should not leave it, otherwise patient will develop neurological deficit. Junctional area. Now, almost the S1 is missing. Now, reconstruction in this area is going to be really difficult, and one has to actually try to save this situation. And in this situation also, we had to take a purchase in the sacrum and the eye. So in such situation, you have to intervene early. If there is an unabated destruction, you are not able to stop it, it is better to debride it and try to reconstruct the column early. TB spine in a young, very young child, you can see there is a huge cold abscess, and this is a ligamentous destruction, and usually it doesn't heal. Patient has instability. So in such situation, again, the early internal fixation and fusion. Fusion is mandatory. If you don't fuse the spine, in that case, there will be problem with the implant and one can have the implant failure. You can see here, I will use the hard seal rectangle and wires and the good graft which is bridging from the cervical to occipital region. At lentoidal tuberculosis, you try to save the motion segment. So if there is a C1, C2 instability, you see if there is an acceptable lateral mass and the bone quality is good, in that situation, if it is reducible, you try to do the transarticular screw fixation. If it is partially reducible, then you do separate C1 and C2 screw fixation. In cases where there is a significant bony destruction and you will not be able to have any purchase in the C1 or C2 region, in that case, you have to extend your fixation proximally into occipital area. And so you have to get satisfied with the occipital cervical fixation. Otherwise, this fixation would fail if your purchase is not good from the beginning. Now, this is a case where it is reducible AAD. Here it has been actually fixed nicely with the transarticular screw fixation and the Galli's fusion has been added. Another case which is an irreducible AAD, you can see the alignment is not here maintained, it is still not fully reduced. So in this case, C1, C2 separate screw fixation has been done and it has been aligned properly and then it has been fused. Fusion is a must because if you don't fuse, then later on there may be problem. So this has done and worked well. A TB spine with neurological deficit. Now you must assess the factor which has led to the deficit. Now, most of the time there is a mechanical compression, there are elements of neural edema, there is instability, and sometimes you do suspect in substitution whether it was a vascular insult, a certain deficit, and you start thinking in that direction. Assess the severity of the deficit. In some situation, if the power is grade 4 or maybe grade 3, and if there is a concentric collapse, there is neural compression, still these cases can be treated with the bed rest, AKT and steroid. Actually, many of these cases, they improve nicely, but here there is a concentric collapse, past granulation tissue, everything heals nicely. And such situations, you need not jump to the surgery, give time it to act. Now, if the patient has dense deficit, there is a bladder wall involvement, there is circumferential tight compression, unacceptable kyphosis, there is a translation, and there is a existing instability. In such situation, you must intervene and early surgery is required. So if patient has come with the neurological deficit, no kyphosis, in such situation, you follow as if you treat a case of tuberculosis, you start AKT, follow the patient, and if it heals, there is no problem. It improves neurologically, no problem. If patient has kyphosis, whether it is a wet lesion or it is a healed lesion, in wet lesion, single level, mild kyphosis, no translation. Again, you initially try to treat it, he might improve. And treat as other case as you see for neurological deficit, whether there is an early deficit and patient might improve. If there is a significant kyphosis, there is a translation. Apart from decompression, there is a golden time to correct the deformity. So in wet lesion, it gets corrected very nicely. The healed lesion is totally a different set of patient where there is a late onset due to internal gibbous, where you want to do the decompression, and you should always try to do the column shortening procedure because otherwise there may be problem of the deficit. You further add to the deficit or patient sometimes it might become significantly neurologically bad. So the procedure which has been described is the axial procedure, particular subsection osteotomy or VCR, and you must try to reconstruct the column nicely so that it is a long-lasting result. Now, in wet lesion, sometimes you get a lesion like this, where you feel that you would be able to save these two pieces of the proximal and the distal vertebrae. If this is viable, then one should not try to excise it. So it is just because of the deformity which has happened because of the collapsing of the proximal segment. The moment we try to fix it and align it, what all you require to do, you have to just create spaces here and put a good strut here. So avoid aggressive debridement. So as soon as you open the lesion, don't put your nibbler. Try to assess the altered anatomy and then you decide. That will be a good way of going in that particular case. And try to assess the bed. Bed is extremely important. Now here, if you excise this, the two discs are open here. So if you put a graft here, there may be pseudoarthrosis. So in that case, you have to have a good bed to have a better fusion, and that is extremely important. So in this case, you can see this strut graft, it is expanding from this healthy vertebra to healthy vertebra. Now, what approach? So principle wise, if you go, the surgery in TB spine, it is an anterior disease. There is an anterior compression and there is an anterior depression. Posterior element is normal, so we should always try to preserve it. Now, dorsal TB and dorsal lumbar area is commonest. So one should try to do the anterior direct decompression. Anterior reconstruction should be done with well-fitting strut graft or case. Inlay graft and onlay graft can be added. And when you choose a fixation module, that fixation thing, whatever implant you use in pediatric age group or adult, try to put on the tensile surface. And the implant should not be too rigid, because we know these bones are osteoporotic and they are inflamed bone. And try to have a segmental fixation, and then you achieve a good correction also. So this is a representative case. You can see there is a lesion, and if you see this, this is a case where there is a translation, angulation, and circumferential compression. So you wish to address all these. Now, usually in such situation, I use this versatile approach. And here, through the single incision, you can go anterior and posterior simultaneously. And then if there is a significant posterior compression, you can do the posterior decompression. And here, usually I use sublaminar wire and hard seal rectangle. Then you can go anterior and decompress and nicely put your strut graft there. You can add inlay and outlay. So this is the immediate post-op X-ray. You can see there is a nice alignment and long follow-up. I have almost follow-up of 30 years and there is no problem. This is the cheapest implant you can get. I can treat a TB case in a municipal hospital in 4,000 to 5,000 bucks. So this is the only expenditure the patient has to pay. So for our country, this is the very good implant, and you never repent for this. Other commonly used approach, which is very widely used nowadays, is the posterolateral approach. But there may be posterior element violation, so you have to be careful. While doing the decompression also, you have to be careful. You should not retract the cord, because that can lead to problem. And the meticulous reconstruction is extremely important, because in such situation, you go from lateral and try to come anterior. So the reconstruction should not be jeopardized. But if there is a poor reconstruction, then there will be late failure and the collapse of the column, and then the implant will give way. Now, this is one case. I will just show that how to do it from posterior side. So this is the proximal and this is the distal area. And then you take the graft, and this is the tricortical graft which has been harvested. And you can see here, after debridement, you can push this graft and nice reconstruct anteriorly, and then you stabilize it. So here you can see this is bridging nicely, and this patient feel nicely. Now, another case, significant compression posteriorly. Now here, you need not debride each and everything. Whatever is compressing, so from this side, we approach and took out that thing, put the bone graft and also the cage, and it. If you analyze this case, the bodies are appearing okay, but you know, there in the canal there is a compression, there is a posterior compression also here in this case. So here this has been nicely done from side. Again, posterolateral approach, the laminectomy defect you can see, and here you can see the body has been preserved same way. So nothing has been done there, and it is improved. When to go anterior? If there is a cervical spine problem, there is an anterior compression, and you want to do the anterior reconstruction. When there is a reconstruction of the extensive cervicodorsal and lumbosacral junction lesion is required, and when you have to have a long lumbar reconstruction, then you have to go anterior. Now, the examples in cervical spine you can see here. So just debride this area and try to reconstruct anteriorly. Now, remember, these are the plate which are working as a buttress plate. You must have to have a good lordosis here. but though the plate has been contoured, but still you have to support externally and ask the patient not to bend forward too much, otherwise there will be problem. If you have a long reconstruction here, then you have to support posteriorly also if you want a very sturdy and good column. But this is sufficient, and many cases we have seen that it feels very nicely. You need not go posteriorly. Now in this case, very young child, I was just struggling which implant I should use in this case. Only collapsed column. So first initial traction was given, and then one of the edetic rod was bent and subluminal wire, and then I had to reconstruct entirely and put the patient into cast for some time, and this patient ultimately healed. CD junction, everything can be done from front here. Almost this is the junctional area. There is a compression, significant compression. It has been reconstructed nicely, and patient improved neurologically. Lumbar spine, again, to save the motion segment, the pedicular screw has been put on one side, and then turn the patient anteriorly and then reconstruct with a good graft. The heel region, it is a totally different ball and chain. Now, if you wish to correct this, you have to do the column shortening procedure only. Don't try to stretch the column. And if the patient is already having a neurological deficit, then the high chances of deterioration. So there are few procedures which has been described: Excel procedure, pedicle subsection osteotomy, or VCR, that is the vertebral column resection. You must address the apex, because there lies the problem. And to have a good biomechanical alignment, good anterior reconstruction, all these points are extremely important. So here the Excel procedure has been done, and this was improved significantly. Another case, pedicular substruction osteotomy, you calculate this, you make a wedge shape and then gradually correct it. So here you must be careful that there should not be any crowding posteriorly, otherwise that can lead to problem. So here the wedge has been closed nicely. You should do a generous laminectomy posteriorly so that there is no impingement from the lamina. Severe cervicothoracic kyphosis with deficit. This patient also was a child, bedridden child. He had come, and here again we did the same thing. VCR was done. Proximally we put the reduction screw. This was the polyaxial screw. Then loosen the area, excise from both the side, and always have to have the temporary fixation, and gradually then you correct the deformity, and anterior reconstruction is important. So this was pre-op, post-op, and this child improved and started independent walking. He improved nicely. So I'll conclude: the adherence to principle of surgery, proper perioperative planning, meticulous execution of surgical strategies in indicated cases gives long-lasting and rewarding results in management of PD spine. I thank you very much for your kind attention.
Thank you, Dr. Srivastav. Thank you so much for such an informative and scientific talk, right from the CV junctions to the sacrum. Right. We'll go on to for the question and answers. Sir, Dr. Shankar, sir.
Yes. Dr. Srivastav, can you stop sharing the screen, and then we'll take on the question answers. Thank you, Professor Jain and Professor Srivastav, for this excellent talk. I think they are both stalwarts in these fields of tuberculosis and surgical and principles and management. First, we'll take questions for Dr. Anil Jain. There was a question by Dr. Sushil himself that in case of doubt in diagnosis, which should be the best combination of investigation? So if the classical picture, as you said, of the 7 signs, clinical radiological picture of subtate abscess, paravertebral extension, preservation of disc space, multiple vertebral collapse is not there. And as you showed in a case where you have multiple vertebral destruction, where less abscess is there, what is the best combination of investigation?
As I said in the beginning, that whenever a tissue is obtained, it should be submitted to all 4: molecular, gene experts, and LPA, culture, histology, and AFP smear. Why I believe that? Because in that study, which after the index TB guidelines, when there was no molecular data, we took a prospective series with National Institute of Tuberculosis for analysis of tissue sample. And what we found that in gene experts and LPA put together 90%, we were able to get the diagnosis of demonstrate mycobacterial genes. AFP was about 45%, 46, 47%. With AFP, with culture, it came about 69%. With gene expert, it came about 100%. So the bottom line is that if you have enough tissue, submit for all. However, there are situations sometimes you do not have enough tissue. In that case, because you have done percutaneous, in that case, I would prefer that you give first for gene experts and LPA, because these are virgin cases, first instance cases. If you are able to detect genome of mycobacterium with additional information of resistance against rifampicin and INH, then that is the best thing. And then the second, that you go onto AFP smear and histology, and then culture, because culture takes time to show the growth of the organism. But ideally, all four.
Sir, as a corollary to that question, as a corollary to that answer, when you ask for a CT guided biopsy, what would you recommend us to write? CT biopsy for gene expert, histology, and AFP smear, is that enough, or because the tissue is very less? And sometimes
I have to take out of that whole data of 3 research questions, that how many were on CT guided biopsy and how many were open. I think now you have given me a stimulus for another work to analyze only those patients where CT guided biopsy was done. I think most of the time in CT guided, you are able to get molecular and histology for sure. And even culture was good number for CT guided. I think maybe I can give this answer in next 2 to 3 months, that out of all, how many were CT guided biopsy, where I could get tissue for culture, where I could get tissue for molecular analysis and histology.
Thank you, sir. So another one quick question is, when you have got a CT guided biopsy that has not come inconclusive, then you counsel the patient for a percutaneous, for a transpedicular biopsy, and that also comes inconclusive. And then where do you go from there? Because the patient has spent already quite a lot of time and money, and then the patient says, "Ab kya kare? What to do next?"
See, my take is very clear. If I have a classical case on MRI, I may tell him very clearly that, look here, you have tuberculosis and I'm treating you for tuberculosis. However, we will have to keep in mind that there would be some percentage which may be drug resistance. We will come to know later. However, when there is a doubtful case, in that case, I will definitely for sure will say that, okay, I'm putting you for CT guided biopsy, because I do not do biopsy by myself. It is done by one radiologist in Delhi who's doing it for the last 10 years for me. And I tell him that when he puts a needle, he has to take a picture and send that picture also, where I could see that needle was, where was the needle. So that way I take control of my CT guided biopsy. If that is not negative and you are not able to get enough tissue, then patient has to be told clearly that I have tried percutaneous method. Now I have to take tissue, because your case differential diagnosis is huge. It's tuberculosis at one end and then myeloma, lymphoma at other end. So your diagnosis has to be ascertained.
Okay. Thank you so much, sir. And there's another question from Dr. Raj Velamur from Toronto, Canada. Can both comment on the psychological aspects of tuberculosis of the spine? So this across continents and
Actually, this is an extremely important question actually, and I think in the planning for anything, even your medical treatment, actually there were times when I used to tell the patient, I will not operate on you unless I am sure that you will be getting AKT. Okay, so this is the issue, because sometimes what happens, patient, you are aware that patient has deficit, you have to operate, but he is from a very poor socio-economic status. Even though the drug are available now, government is supplying, the compliance is very important. You know, the parents has to be told beforehand that this is the problem. If you don't, stick to the protocol, then you are going to have the problem. I actually lost a child who developed meningioma, tubercular granuloma, not meningioma, I'm sorry, tubercular granuloma. And the TB was everywhere and we could not save that child. So this is a pitiable situation in our socio-economic, status society, where there is illiteracy. People, they're coming from the villages, though we wish to follow them, but this is a big issue. And I think we have to take into consideration of this. Now, the girl which I showed you, she was so nutritionally poor that we had to wait for surgery to make her hemoglobin build up and nutrition, her protein, and then only we could take. Otherwise, you can lose the child. Before you go for the posterior surgery and anterior surgery, all these things, theoretically it looks very easy, but practically you have to work on this. The socio-economic status is one of the things, apart from the psychology which the patient is going through, and the parent psychology also. So both these things, the psychology also, it is related to socio-economic status. What is the economical status of the family, how much learned or well-read they are, or they are totally uneducated. All these things have a bearing. I think Dr. Jain, he has followed up his patients for pretty long time. I think he can also give input into this.
I think I fully agree. The talking to the patient is the key. I have treated all poorest of the poor in a government setup for last 30 years. And if you ask me, see what way I found out was easier for me, that when the patient came for the first time, I just told him that, look here, you will be investigated for certain things. And then I will talk to you once we are finished with the investigation. And before starting a treatment, I ensured that I give 5 to 10 minutes myself, telling the patient the implication of a regular treatment, implication of full treatment, implication of no treatment, and what is my plan as far as your case is concerned, whether I'm thinking just to treat the disease, or whether I'm thinking to operate you for deformity, whether I'm going to treat you, and even for neural deficit, if it is there, then how it is going to my expectation. So if I generally 5 to 10 minutes, patients remain so satisfied. Now the third issue comes when they go to field, then they have to collect drug from DOT center. And I have evolved in the DOT strategy from that time when DOT centers were just stopping ATT without consulting at 6 months or 9 months, and no direction were available from the government. So I used to tell these patients that, look here, whenever your drug is going to be stopped, when you get your last batch of drugs, then you have to come back to me. You will not stop the drug unless I tell you to stop. And then till today, I have not come across a patient who has been a defaulter, because my follow-up of all research projects, they were almost 30 in number, and none of them, the follow-up was ever a problem. Even now, I'm retired for last 4 months. My drug resistance data is being analyzed, and all patients are coming on a given day when I used to call them. So about talking to the patient is very key, very important.
Extremely important. That is extremely important.
Just wanted to know, sir, do you involve a physician or a neurologist in treating multi-drug resistant?
But to begin with, I was treating the second line drug myself, prescribing second line drug till 2018. Now I have involved a physician from National Institute of Tuberculosis, because now newer drugs are coming, their availability of drugs is improved, and now they are working on a shorter duration, short-term duration regimens. So now it is a close coordination, and I would always recommend that you should have one pulmonologist or one multi-drug resistance expert in the loop.
Yeah, okay. But one thing, Dr. Jain, since there is a large group of physicians here, I have seen that a lot of times when you start anti-tubercular treatment and then after 3-4 weeks you get hepatitis, and then a lot of modification is either done by the physician, by the surgeon himself, or is sent to the physician, then who immediately takes him off the drugs. There I find still a lot of confusion. Would you like to
I
share
think
some of your thoughts?
what we follow is that we in the same institution we admit the patient and we discuss with the physician. This all stoppage and reintroduction of one drug and second drug and third drug is done in close collaboration. We are in the loop, they are in the loop, and both of us are discussing.
If it is on the first line treatment, if the patient is on the first line treatment, how often you carry out this liver function tests and everything?
Generally, when you start ATT, every 2 weeks to begin with, and after 3 months you can get every month, because after 2 months pyrazinamide is off, so one hepatotoxic drug is off, so after that one can go once in a month, or later on twice in a month, because rifampicin and INH, those 2 drugs are left.
We often involve physicians into it so that they can actually
see, mild increase in enzymes is possible. Up to 2.5 times, it doesn't bother. Beyond that, it becomes a little issue. But I think empirically reduction of 1 drug and 2 drug and 3 drugs should not be done. And I think this liver flux is creating a problem, because you give rifampicin, INH, ethambutol, pyrazinamide, and then physicians are in habit of adding liver flux also. So now then the derangement comes a little faster.
Okay, if there are no more questions, Dr. Sushil and Dr. Aditya, we can then close. If there are any questions in chat box, no.
No, I was just listening to one of the comment about the neural deficit and surgery. Sometimes these dry lesions, Dr. Srivastava showed one very good case where the neural deficit and they need to be operated. So when you see on your MRI that it is not liquid pus, then probably most of the time, in kyphotic spine, it is the disc that is the offending cause of pressure onto the spinal cord, and there is no need to wait for some weeks to show improvement and then operate. In dry lesions, we should operate quickly.
Yes.
I think that was an excellent session, and both the speakers, Professor Jain and Professor Srivastava, delivered excellent concepts of how to treat and when to operate. And thank you so much, sir, and thank you, Dr. Aditya Bhati, for having coordinated this session as chairperson, and Dr. Sushil Jain, who is now taken over as the Gap Year advisor. There is one raise of hands from Dr. Kachu Ravi Chandra, and with that we can close the session. Thank you so much to GAPIO and ASSI coordinators and all the IT organizers and everybody. Yes, Dr. Kachu, your last question you can say, and then we can close.
He's from Secunderabad, Yashoda Hospital. He's a neurologist.
Yes, sir. Can you unmute yourself and ask your question?
Dr. Ravi, please unmute yourself and please.
Good evening, respected teachers. Sir, one question, sir. Last around 15 years back, we have treated one young boy who is around 22 years. He came with paraplegia. He came to us after 20 days of the paraplegia. He was treated outside. And when he came here, his both lower limbs power was 0. So we thought the decompression will not work initially. So we counseled the patients. They were willing for the surgery actually. And we started ATT for 1 day. Then attendants are forcing us. We have done decompression. I don't know the miracle or what is it, sir. Now he's walking, sir. So these things are who is paraplegic, pot spine. It happened with surgery only. He improved with surgery only. So
Dr. Srivastav, you want to come and answer that question?
Actually, if I have
Sure.
understood the comment, in that
Sure.
case, I think this patient had paraplegia since I think 20 days or so. Am I
Yeah.
right?
Yes, sir. More than 20 days actually.
More than 20 days. And then
Yes, sir.
you came and then I think you started AKT and you operated and
Yes, sir.
and the patient improved.
Yes, sir. 100%. He's walking, sir, without support anything now.
Yeah, that is good. Actually, that should happen. That should happen. That is a usual thing we expect also to happen. That if you have decompressed the thing, and patient should improve, and patient should show recovery. Since you have intervened early, it was since 2-3 weeks only. So I think that is the good outcome, and I think we expect that.
Sir, he improved over a period of 6 months to 1 year, sir, actually.
Yeah, usually we have seen the patient with the grade 0 power, the spasticity
Yes, sir.
will be for a long time, but gradually it improves. If you have decompressed the cord nicely, if you have stabilized the column, if the component of instability was also there, in that case, they improve fast, and some part of spasticity remains, and that also recovers.
Thank you, sir. Thanks a lot.
Okay, I think that was that's a quite a relevant question, and Dr. Jain has also written that tuberculosis spine, the compression is slow and chronic, and there are multiple elements. And we have always seen that patients who present to us with paraplegia, even spastic or others, then later on they will improve. So that is different from trauma, and we should not confuse traumatic paraplegia with tubercular paraplegia. So that's already well documented and shown. And with this, I thank all the speakers and the audience and everybody for this great session. And thank you so much.
Thank you, everyone. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.
Namaste.